Welcome back. We are now going to look at cyclothymic disorder. Cyclothymic disorder, also known as cyclothymia, or is it cyclothymia? Cyclothymic is a chronic mood disorder characterized by recurrent fluctuations between hypomanic symptoms and depressive symptoms that do not meet the full diagnostic criteria for a hypomanic episode or a major depressive episode. According to the DSM-5-TR, it is classified under bipolar and related disorders. Although symptoms are milder than those of bipolar 1 and bipolar 2 disorders, they are persistent and can significantly impair social, occupational, and interpersonal functioning. According to the DSM-5-TR, the following criteria must be met: numerous periods of hypomanic symptoms and numerous periods of depressive symptoms that do not meet the full criteria for hypomanic or major depressive episodes. Symptoms have been present for at least 2 years in adults and at least 1 year in children and adolescents. During this period, symptoms have been present for at least half the time and the individual has not been symptom-free for more than 2 consecutive months. The symptoms do not meet the criteria for major depressive disorder, bipolar 1 disorder, bipolar 2 disorder. Symptoms are not caused by substances, e.g. drugs or medications or another medical conditions. Symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Clinical features of hypomanic symptoms: individuals may experience increased energy and activity, elevated or irritable mood, increased talkativeness, reduced need for sleep, inflated self-confidence, racing thoughts, increased goal-directed activities, mild impulsive behavior. These symptoms are less severe than mania and do not usually cause marked impairment or require hospitalization. The depressive symptoms may include low mood, fatigue, poor concentration, reduced motivation, feelings of hopelessness, low self-esteem, sleep disturbances, appetite changes. Unlike major depressive disorder, these symptoms do not meet the full diagnostic threshold for major depressive disorder. Then causes, which in abnormal psychology language would be etiology. Cyclothymic disorder results from an interaction of biological, psychological, and environmental factors. The biological factors are genetic predispositions such as family history of bipolar disorders, neurotransmitter imbalances involving serotonin, dopamine, and norepinephrine, brain structure and functional abnormalities. The psychological factors: maladaptive coping mechanisms, emotional dysregulation, personality traits such as high emotional sensitivity. Social and environmental factors: chronic stress, traumatic life experiences, family conflicts, substance misuse. Differential diagnosis, very important. Cyclothymic disorder should be distinguished from bipolar 1, bipolar 2, major depressive disorder, borderline personality disorder, substance-induced mood disorder. And bipolar 1 disorder, bipolar 1 includes at least 1 manic episode. Cyclothymia does not include mania. Or is it mania? Bipolar 2 disorder. Bipolar 2 includes at least 1 hypomanic episode and 1 major depressive episode. Cyclothymia includes only subthreshold hypomanic and depressive symptoms. Major depressive disorder. MDD has major depressive episodes without hypomanic symptoms. Borderline personality disorder. Mood changes are rapid and usually triggered by interpersonal events. Cyclothymia has more sustained mood fluctuations over time. Substance-induced mood disorder. Mood symptoms are directly related to substance use or withdrawal. Assessment of cyclothymia includes comprehensive clinical interview, detailed psychiatric interview, mental status examination, mood charting over time, family history of mood disorders, screening for substance use, medical evaluation to exclude physical causes such as thyroid disease. Treatment would be psychoeducation, psychotherapy, medication, lifestyle intervention. So psychoeducation, educating the client and family about the nature of the disorder, early warning signs, importance of treatment adherence, lifestyle management. Schizophrenia requires the same treatment, by the way. I personally would recommend the same treatment for schizophrenia. Psychotherapy, cognitive behavioral therapy, that is CBT, interpersonal and social reason therapy, IPSRT, which focuses on its IPSRT. That is how my brain is reading it, which focuses on stabilizing daily routines and sleep patterns. Family-focused therapy, supportive psychotherapy. Medication may consider if symptoms significantly impair functioning or there is a risk of progression to bipolar disorder. Options include mood stabilizers, certain atypical antipsychotics in selected cases. It's important to note that antidepressants should be used cautiously because they may trigger hypomanic symptoms in susceptible individuals. Lifestyle interventions: regular sleep schedule, stress management, regular exercise, avoidance of alcohol and recreational drugs, building strong social support systems. I would say somebody who has cyclothymia should not be in relationships that are triggering, or the relationships just aren't stable. The relationship is not stable, these people should not be in those relationships. Prognosis: the prognosis varies depending on early diagnosis, treatment adherence, family support, presence of co-occurring disorders, that's comorbidity. Without treatment, approximately 15 to 50% of individuals with cyclothymic disorder may later develop bipolar 1 or bipolar 2 disorder, highlighting the importance of early recognition and intervention. Nursing and counseling considerations when it comes to cyclothymia: counselors and mental health professionals should build a strong therapeutic relationships, monitor mood changes and functioning, encourage medication adherence where prescribed, teach coping, emotion regulation skills, involve family members in psychoeducation and appropriate, develop relapse prevention plans. Relapse is very, very, very high, and a good relapse prevention plan would be including making sure the family is involved in this person's treatment journey, and following up on their relationship history, friendships, romantic relationships, and even family members who may be stressors. Because if family members are stressors, if friends, partners are stressors, this person is very likely to relapse. It would be difficult to manage this when the person who is dealing with cyclothymic disorder is dependent on an abusive family member. Could be a partner, could be a parent, could even be a child or children. Cyclothymic disorder is a chronic bipolar spectrum disorder characterized by fluctuating hypomanic and depressive symptoms that do not meet the full criteria for bipolar 1, bipolar 2, or major depressive disorder. Although symptoms are milder, they can significantly affect quality of life and may progress to more severe bipolar disorders if left untreated. Early diagnosis, comprehensive assessment, psychotherapy, appropriate medication when indicated, and ongoing psychosocial support are essential for effective management. And I have a table that differentiates the cyclothymic disorder, bipolar 1, bipolar 2, and it's a free template on Canva. The link is in the description. You can go download it, and it could help you. You can leave your comments on the template on Canva. And then also in this video, you can comment below. This is for revision purposes. I'm just saying what I'm revising. What I'm revising may not be accurate like 100%. There may be error somewhere. I'm open to correction. You can even ask me questions in the comment section below. Let's go to the next part.